Well, thank you very much, Dr. Lois Lopez, for inviting me to come and give this talk, and for all your hospitality. So the concept of acute stroke management, as far as I can see, is not just to remove a clot from a pipe, but to think of a person as a person who's had a stroke and who needs to be treated in completeness, rather than just removing a clot and being done with it. So I think right from the word go, it encompasses three things: saving the acute situation, secondary prevention, and management of some oddball strokes that may or may not be strokes. So, which always poses a challenge. So, there's no talk that cannot mention NINS, which was the pivotal trial that actually showed that TPA can work. And TPA does work, intravenous TPA does work, but in a limited way. So overall, the trial did show that there was a 13% absolute improvement in outcome with the IV TPA, given all comers. And there was an acceptable risk of intracerebral hemorrhage. But if you break it down, you can see that the majority of the benefit was obtained in mild to moderate strokes. So if you look at the numbers by the NI stroke scale score, you have the NI stroke scale score between 6 and 10 is where the maximum benefit was seen in stroke management. And as the numbers increase, the stroke severity increases, the benefits go down to almost none. So this right from the word go, it shows you that you cannot treat all of stroke patients with IV TPA, which was mandated by the FDA at a certain point, which we didn't agree with, and we didn't do it. We have Dr. Linfonte, one of my colleagues who started the interventional program at UMass Medical Center, with us. So we right from the word go, we had a different paradigm outside of which was built outside of the proposed NIH system. And I'll just skip a couple of slides. I mean, it also, the two other important studies that I think I should mention, the European Cooperative Stroke Study 3, that actually extended the window of TPA from 3 hours to 4.5 hours, but with decreasing benefits. So as you can see that they had a selection bias, that they did not include severe cases. They had patients that with prior strokes were excluded. So there was a fairly selected population that was chosen in this. And what they found was that the benefit was about 7%, not 13%. So it does say that time does play a role in terms of management. So the sooner you do it, the better it is. But that's not the only component. And then if you look at these two other trials, the Atlantis and the ECAS-2, they actually showed that although they were negative trials, but they actually demonstrated that patients could benefit up to 6 hours. If you took a different outcome measure, if you did not take outcome measure of 0 to 1 on the modified Rankin scale, but a 0 to 2, then of course the trial was a positive trial, and it does show that it's acceptable level of disability even if you treat at 6 hours. So the things that define and determine our program was based on these things, that you need to recanalize arteries, of course, we all know that. You need to determine which patients actually need recanalization, and that is the penumbra. So you need to define what is the penumbra, you also need to take into consideration whether the patient had previous ischemic conditioning, what are the stroke subtypes, and what are the comorbid conditions. So taking all of that into consideration, you can have proper patient selection for either intervention or no intervention or conservative treatment. Again, a very important ultrasound study that demonstrated that patients giving IV TPA, the large arteries do not open up. So ICA, basal artery, the recanalization rate is about 8%. But as you go forward to the middle cerebral artery and distal branches, the rate of IV TPA increases significantly. And again, the other important thing with IV TPA is the clot burden. So the longer the clot burden, the less chances that IV TPA will work. Now, what are the things that actually determine what the penumbra? That's the objective of the whole intervention or any other strategy in trying to treat stroke. So what are the determinants of the penumbra? So what saves the ischemic area is collaterals. The more collaterals you have, the more likely you are to extend the window beyond 2-3 hours to 6 hours or even longer. And secondly, if you have ischemic preconditioning. Thirdly, if you've been on taking statins before the stroke onset. And then prior use of antiplatelet drugs. So patients who are on aspirin before the stroke onset actually tend to do better in terms of their outcome. And finally, the stroke subtype, so, which says that cardioembolic strokes are actually the worst type of strokes to treat because there's none of these things apply. The collaterals don't develop in time, and you don't have any ischemic preconditioning. From the very beginning, we decided that we would not do MRI-based interventions because it's a waste of time. You use about 20-30 minutes with neurosurgery and intervention. So they were all transferred to UMass, to the stroke unit. And by the time they got to the UMass, it was about an hour. That's the geographical location. And IVTPA would be done because we would just start IVTPA and drip and ship them to UMass. And then they would go, if they have not improved, they would go straight to CT angiogram. And if the CT angiogram shows occlusion, they would go to intervention. So that was the route was the same, regardless of whether we were dealing with a peripheral hospital or we're dealing with a central hospital. Here's an important paper, again, that helped me think through this process by Dr. Savers, that actually showed that IV therapy works in about 46% of all comers, and IA works far more effectively, and that patients that actually recanalize, the important key factor is recanalization in time, are 4.5 times more likely to achieve a good outcome at 3 months. And this is a case that I think Dr. Linfonte and Dr. Baklu were both involved with. And this is a young woman who had an MCA occlusion, got IV TPA, and just in the beginning, the system was not very streamlined. So we had to wait because there was another case on the table. While this woman was lying, after IV TPA, so it was 2.5 hours before, after IV TPA, that she actually got to intervention. And this was the core, and this was the result of the intervention. And finally, this was the post-contrast, post-intervention CT, non-contrast CT, which doesn't show any hemorrhage. This is contrast excavation. And so this woman actually recovered completely. And because she was young, because she had a lot of good collaterals, she recovered completely and was then discharged from the ICU. Didn't have to go down to a step-down unit. She was discharged from the ICU, and 6 months later, stopped coming to even see me in the stroke prevention clinic. So that's how good the outcome was. We always start with concomitant medications in all patients. So high-dose statins are always given, and by high-dose statins we mean 80 milligrams of Lipitor, 40 milligrams of Crestor, or 80 milligrams of Zocor. Those are the 3 high-dose statins that we always give, one of the 3 at the very beginning, as soon as we see the case, if the patient can swallow. If they can't, then we just wait for the first 24 hours. You have to bring down the blood pressure to 185 over 110. And the way we've changed the paradigm is that we don't use labetalol at all, because it's really a waste of time. It doesn't bring down the blood pressure effectively. We just use nicardipine directly. And we've cut down the blood pressure goals to bring 185 over 110 by at least 10 minutes. And 10 minutes is 10 minutes when you're dealing with the acute intervention. Very important, we use dysphagia screening in all patients. So one of the biggest challenges that we had was the patients were not getting dysphagia screening, and they were given food by the ED nurses, and they would choke and have aspiration. So every patient has to have dysphagia screening before they can their NPO till they actually get treatment. And then the use of neurocritical care units has been shown to be very beneficial, and we have at our center 3 trained neurocritical care intensivists who actually manage most of this acute post-acute care. Just to show you what happens if you don't give statins. So this is an interesting paper that shows that stroke recurrence goes up and mortality increases over time in patients who are not given statins. The dotted lines are statins, so you can see that the outcomes are much better, and the spread lines are where the mortality is significant. And this is really the key point. In our own center, we were able to show that statins improve acute ischemic stroke outcome. So anybody who was on statins before stroke onset had a 1.7 times greater, 1.8 times, 1.7 times greater chance of having a better outcome. The odds were 1.7, and the rest, of course, is self-explanatory. If you have small vessel stroke, you'll do better. If you have diabetes or older age or TIA, you would tend to do worse. Now, why do statins work? I think initially giving high-dose statins is the goal is to harness the pleiotropic effects of statins. So you have antiplatelet activation, anticoagulation properties, increase in endothelial cells, progenitor cells, the decrease in endothelin, which is a prothrombotic factor, and then decrease in all the inflammatory cells like macrophages, inflammation, immunomodulation. So, and perhaps the most important thing is increase in endothelial nitric oxide synthetase, because that in itself increases vasodilatation and improves blood flow. So if you have a chance to give high-dose statins right in the beginning, even before intervention, without wasting time, several papers have now shown, I mean, this is not something that is debatable anymore, and it's part and parcel of the Massachusetts Get With The Guidelines program, which is a national program that you should be giving high-dose statins to everybody. Now, of course, if you can't do any of that, then we use rectal aspirin, permissive hypertension. We let the blood pressure go to up to 200 by 140. That's our goal. Antiplatelet agents are given rectally. Oral anticoagulants as soon as possible, and of course, they're admitted to the stroke unit. The challenges are these oddball cases. When patients come with some tingling and paresthesia as an 84-year-old woman, what do? When people come with some little ataxia and a code stroke is called, and in all the excitement, you just start giving them IV TPA, what do? And then TIAs. So I'll just spend a very brief period of time. These are the stroke mimics, and this is our way of trying to figure them out. I mean, if you think about it, migraines have a slow parasthetic march of events. So if you take a careful history for about 2 minutes, you should be able to differentiate a migraine variant from a stroke. Often that's not the case, and these people end up getting most of the IV TPAs, when they shouldn't be giving IV TPAs in these cases. So similarly, post-seizures, if you do a CTA in every case, and if you show that there is an occlusion, and if the patient had a seizure, they most certainly had a post-ischemic seizure, and so therefore they should be treated. And so on and so forth. The hypoglycemia is automatically taken care of because we have point-of-care labs. The only 2 point-of-cares that we require, INR and blood sugar. So as soon as blood sugars are low, you give them glucose, and if they improve, that solves the problem. The more challenging cases are vestibulopathy, and again, it's a simple exam. Have the patient sit on the bed and do a cerebellar exam on the patient. If that is negative, then they have vestibulopathy. They don't have a cerebellar syndrome. And then, of course, other conditions which are too lengthy to discuss right now, but demyelination can, this worsening of an old deficit, the famous locus minoris effect, or decomposition in a structural lesion like a tumor, a bleed in a tumor. Things like that need to be excluded. The other thing is fluctuating neurological deficits. Patients who fluctuate do very well with IV TPA. So if they keep going up and down, most of them are small vessel strokes, and the clot burden is not high, and the results are astounding because even though these patients recover very well without any intervention, but by giving TPA, you've cut down their period of rehab by 3 months because they recover very quickly, and they're almost discharged home or very quickly discharged home from rehab. So unless there's a very strong reason not to give TPA to fluctuating deficits or to patients with very minimal. By the way, there was this whole thing that if you have NI stroke scale score of 4 or less, you should not give TPA. And that's been proven to be wrong because even the FDA now says that you should be giving TPA to anybody who's got aphasia, for example. That's a very serious disability. So even if the score is less than 4, it doesn't matter. These patients do very badly in 3 months. Finally, just to talk about TIAs. So if you take TIAs and send them home after giving them a discipline or aspirin and then ask them to come back to the clinic the next day, the outcomes are that in patients who are high-risk TIAs on the ABCD score would end up having 10% of them would end up having a recurrent stroke or a full-blown stroke within the first 48 hours. And 5% would be really in the first 48 hours. So these are really bad outcomes. So these patients, TIA patients should be treated exactly in the same way as acute stroke patients. They should be admitted and treated for any acute problem before being discharged, which has been shown by this study, the Oxfordshire study, where all these patients were admitted to the acute management study, and they actually showed that there's an 80% reduction in the risk of going on to having a full-blown stroke if you admit the patient for a day, take care of the problem, whether it's large artery atherosclerosis, atrial fibrillation, etc., um, and treat them adequately. So I think TIS should definitely be in the train ballpark. What about wake-up strokes? Nobody would touch them before, but interesting enough, there was a study from Dr. Hichinsky's lab that actually showed that on compassionate grounds, people given IV TPA in wake-up strokes did equally well as the NINS patients who were given TPA within the first 3 hours. So if you look at the two issues, you need to selectively look at the IV TPA, at these wake-up strokes. Do they have a penumbra or not? And so we had a patient, a 79-year-old woman, who was a wake-up stroke and had a very dense deficit, aphasia, right hemiparesis, and an eye stroke score of 23. So our night attending didn't want to deal with this. And in the morning I had to come, I saw this case and I saw this image and I said, take the patient to intervention right now because it doesn't matter. This is going to be a huge left MCA infarct regardless. And so the patient had intra-arterial thrombolysis and thrombectomy, and her NI stroke scales really improved dramatically. Day 2, 16, day 3, 10, and day 8, she was discharged to rehab. So this has been our experience with, in general, if you extend that hypothesis, that IV TPA works very well for M2, M3, M4, but if you take on the right-hand side, you see ICA, M1, T occlusions. In these cases, they do very badly. In fact, 25% die if just treated with IV TPA. And the results are quite different if you treat them with intra-arterial therapy. And you can see that the ratios become very different. Only 4% mortality, and then this huge pie with good outcomes, where patients were discharged home, acute rehab, and some went to, 40% went to nursing homes or step-downs. And the same numbers keep applying. Our overall 90-day mortality is about 10%. So after all of this, it was interesting that all these thrombectomy trials with the stent retrievers came in, and before that, it was almost the case that IA therapy was going to be a thing of the past because every insurance company had started refusing it in reimbursement. So thank God there was this stent retriever trials that showed that this is a comparison of some of the failed trials, the first 3 trials that actually synthesis expansion, IMS3, MRSQ, that actually put the lid on IA therapy because, as you can see, the selection criteria was very poor, and none of them achieved any significance. The only one that came close to significance was synthesis expansion. On the other hand, if you look at the other trials that were done with stent retrievers, including Extend IA, which extended the window almost up to 12 hours, based on the same logic of having a penumbral imaging and saying that, if you have penumbral imaging, you are likely to have reasonably good outcome if you don't have a large infarct. So go up to 12 hours. And so if you look at the numbers, they're astounding. Treated patients had 71%, untreated patients had, untreated meaning that IV patients who just got IV TPA had 40% better outcome. And look at the odds, 4.2, 1.8. Swift Prime had another good study, although they had limited number of patients, but they were actually able to show that the odds of having a good outcome are very good. I mean, in terms of the first study, the Mr. Clean, was the least impressive of the lot, and only because they did not do penumbral imaging. Everything was based on CT-CTA. So it wasn't CTPs. So once, if you don't know what the penumbra is, you're going to miss out cases, you're going to treat cases that may or may not necessarily benefit. So that's why the results of MR Mr. Clean were not as good as you can see with the rest of the studies that actually used penumbral imaging. The recommendation now is what we have been doing for years. I mean, this was our way of treating stroke, that patients should be start with IVTPA, and if they have large vessel occlusion, determine penumbra and take them straight to intervention. Don't wait to complete the IVTPA. Don't wait for anything. Just go. And it was really helped by our two interventionists who were not afraid to go in with IVTPA running. So that took some doing. A lot of people did not do it at that point, say that because you've given IVTPA, we don't want to go in with a device because we'll cause rupture and so on and so forth. But these guys did and actually produced very, very good results. What about conscious sedation? There is proof that, again, that conscious sedation is better than general anesthesia when you're on the table. Patients who are intubated do much worse. Patients who are in conscious sedation actually do much, much better. Just want to say a couple of words of malignant MCS infarction. These are patients who are young, who have no collaterals and have a large infarction. And this is the extent of infarction that you would see in a young 55-year-old person with dissection or something else. And what has been shown by this group in the pool perspective analysis, a very interesting paper published in Lancet, was that if you do an extensive decompressive hemicraniectomy with duroplasty, you improve the odds of survival by 50%, absolute reduction of, so you need to treat two patients for one patient to survive. And you have a reasonably good quality of life in 1/4 of those patients. So 1 in 4 will have a reasonably good quality of life. And we are talking about 80% mortality in this group if you don't treat them. Because MANAGENT and all that stuff doesn't work in this group. I mean, those are temporizing measures anyway. So patients herniate and die, 80% mortality. The trigger is for early intervention. The trick is to have early intervention. And the early intervention is decided by two factors. First is that you have to have infarct. So immediately when you see a patient that has a CT scan infarct volume of greater than 50% of the MCA territory, or a MRI infarction of 146 cc or more, this should immediately trigger that this patient is going to possibly develop malignant MCA syndrome and will need early intervention. Close observation, and the moment they lose one level of consciousness, I mean, one point on the level of consciousness and then I stroke scale score, decompression. I mean, that's the time to intervene. The time is not to wait for 48 hours or 72 hours to intervene. All right, so I'll skip this. We've talked about these trials. I mean, if somebody wants to have a more extended discussion, we can do it later. But all of these trials were based on careful patient selection, which is the real key. You cannot treat every stroke patient in the same way. Surgical management is, of course, very clear. I mean, it's been known for years that greater than 70% stenosis of the ICA patients do have a 17% absolute risk reduction in recurrent strokes with surgical management. Not so well defined for asymptomatic carotid artery stenosis, where the risk-benefit ratio is so narrow that if you try to intervene, chances are that you may end up doing more harm than good. And the important thing about this is that this was done at a point when the aspirin was the only comparison that people had to go by, aspirin versus surgery. So now we have many more drugs that can actually reduce the progression of arterial stenosis, including high-dose statins. So we've seen with the combination of drugs, blood pressure control, excellent diabetic control, that patients who are 65% remain 65%. They don't progress like the old days when people used to, were expected to progress on a yearly basis and at some point would get surgery. The timing of surgery for us, for TIAs or minor strokes, 48 hours. For larger infarcts, 2 to 4 weeks. And of course, if it's a really large infarct and if there's something to save, then we will wait 6 weeks to see what actually has been saved and then decide on surgery. There's no point in trying to open up an artery if there's no brain. Patients who are younger do well with stenting. Patients who are older do well with the classic endarterectomy. And the reason being that atherosclerosis is much less in younger patients. So to dislodge stuff while you're going up to the brain and causes secondary strokes, the chances are much less in younger patients as opposed to older patients. Finally, just a couple of lines on all of this is great, but this affects only 5% of all stroke population. What really affects patients is this. Reduce hypertension, you reduce the overall chances of a bad first stroke or recurrent stroke by 40%. Smoking, diabetes, hyperlipidemia, or atrial fibrillation. I mean, these are some of the big ones that you can address as an outpatient. It's not terribly exciting. You don't get the adrenaline rush by pulling out a clot, but this is the most effective way of treating stroke rather than the acute management. And finally, these are the drugs that we talked about. We have now 4 drugs that, besides warfarin, that one of them is direct thrombin inhibitor, and the other 3 are factor Xa inhibitors. And all of them are, the good thing is that they become therapeutic right away. So you give the first 2 doses and the patient is therapeutic. Unlike warfarin, where you have to wait for 5 days slowly and bridge it with something to get the patient therapeutic. So all of these drugs have that particular advantage. And the big fear at that point that held these drugs back was, what if somebody bleeds? Well, if somebody bleeds on warfarin or anything, the outcome is going to be bad, unless you get somebody very, very quickly in the hospital. So, but anyway, regardless of that, now that is removed because we have antidotes or reversal agents for all of these drugs available. So now with confidence one can say that, these patients should be treated with these safer drugs because they have lesser risk of intracranial hemorrhage and they are able to reverse. The advantage is no lifestyle modification, fixed dose, and no blood draws. I mean, that's huge in terms of quality of life. I think this is my last slide. So we are now moving on to this unknown area of embolic strokes of undetermined source, or popularly called ACUTE. ACUTE is a topic, is about 30 to 40% of all ischemic strokes now. And there are 2 ways of dealing with ACUTE. I mean, the most rational way is there are 3 trials that are looking at this. One with Xarelto, one with Dabigatran, and one with Apixaban. One is an NIH-funded trial, the other two are company-based trials, but they are all looking at the same thing, that in this particular patient population where atrial fibrillation is supposed to be a strong underlying cause, but has not been picked up, can treatment with one of these novel and oral anticoagulant drugs compared to aspirin reduce the recurrent stroke rate and the subsequent mortality? And that's, in fact, there was a very nice paper in Stroke, which I would encourage everybody to read, 2 months ago, that showed that, interesting enough, the outcomes were the same at 1 year in ACUTE patients versus other patients, but recurrent strokes were far more common in the ACUTE patients as compared to other treated patients. And so that's pretty much it. Patient selection is important. You need to have a viable penumbra to treat anybody. Rigid time windows are something that should be a myth by now, and that all patients should be assessed on an individual basis to see if they have a viable tissue penumbra core to be saved. And if so, then time really doesn't matter that much, and you should make an effort to treat them. So I would like to thank everyone for being patient and being able to listen to me. Thank you.
Is there any question in the audience? I have one question. And with those patients with fluctuations in the stroke, do you think about timing, or you really don't care if this fluctuation is for the last 24 hours, 48?
So the good thing is that even if this fluctuation for 24 hours, 48 hours, your clock starts from the time when they were last well. So you should take it from the last fluctuation, okay? So, and as long as the CT scan doesn't show multiple infarcts, you're good to go.
There's another question here.
Yeah, can I ask you a question?
Sure.
Well, thank you for the beautiful presentation. As we are using more and more statins, and some of the problems with the statins became already known, do you have any alternatives? Do you have new drugs to overcome those problems with the statins?
So the commonest problems that were initially, when the most common problems that were thought to be important were that people will develop gastric cancers, people will develop memory loss, people will develop muscle ruptures. So none of that happened because that was shown in an 11-year follow-up of the heart protection study, where people used 40 milligrams of Zocor for that period, and none of that happened. The most important thing that and the most common thing which affects people is 3.5% is muscle cramps. And thankfully, muscle cramps are not a class effect. So you can change somebody from atorvastatin to some other statin, and be able to get away with it in most cases. I mean, at least my strategy is to move from a lipophilic drug like Zocor to a hydrophilic drug like atorvastatin or Lipitor. And if that doesn't work, then resort to the simplest thing, or the mildest drug, which is pravastatin. It always works. And rhabdomyolysis, which is the most dangerous complication, is seen in 1 in 1 billion. I mean, it's that low. Thank you.